Yeah, we're gonna start with targeting, and pretty much this is probably the most important part of. This is the most important part of the case, right? If you have bad targeting, if you start at a bad location, it's just going to make the case that much more difficult for you. So we really want to kind of tease out all the different positions or parts of each individual procedure so that you guys can see the little nuances. And so with this approach, we're going to go over every individual step, not just targeting, but soft tissue handling, the bony removal, and then of course different techniques and things you can use to progress your case and make your case more efficient. So Meng Huang, he's in the lab getting set up, and then after that we'll have Saqib Hasan. He's going to then go over interlaminar targeting, and then Jon Yoon will finish up with biportal techniques.
Just one thing for the audience here right now. A lot of people have done endoscopy. So who has gotten lost here from the skin to the target area so far, during their career? Anybody else?
Yeah.
Okay. And then does anybody want to share why that happened? Because this is really important. Targeting is, why you wouldn't embrace and wouldn't, you wouldn't start it, right? Because you're like, from this point on the skin, I have to get right there. And if you get lost, you're really lost, right? You don't see anything, you see muscle tissue. So anybody wants to share their experience while we start?
Yeah.
It was a large patient, and I thought I had a good x-ray, and I thought I was lined up, but it wasn't as perfect an x-ray as I thought. So once you get down there, you quickly realize that what you thought was the perfect x-ray actually needed a little bit of adjustment, and a few millimeters from a far distance will extrapolate and be centimeters at the target site. So that's what ended up happening. So.
And that's a very common thing, is having the x-ray not perfectly lined up. Super, super great example. Any other thoughts to share while we set up? And John, you can
just further even to what was your name? Shahid, to Shahid's point, a lot of people start with an x-ray and you're not having that index level in the center of your x-ray beam. So there's going to be some parallax. And I would say, early on in my residency training or fellowship training, I would settle for crappy x-rays, and then Christoph would come into the room and say, what is this? What are you doing? You're wasting time. And it became very apparent to me that if I wanted to get quicker, I need to be efficient. So getting the perfect x-ray first, and then starting from that x-ray, and then making the maneuvers or the C-arm beam to get your target approach is very important. And I would say it's even more so important as you're making these small incisions, using these small instruments to target on a very specific part. And then I think the other thing that we kind of don't think about is, there's always going to be, to some degree, a little bit of tactile feedback that you're looking for. So if you're targeting a specific landmark, let's say in the transforaminal approach, you're trying to get to the SAP. If you feel bone and you don't feel it slide forward to get into the framing, then maybe you're not on the SAP, and that's when you want to, contact bone, take a lateral, confirm that you're where you think you are, go back to an AP, and progress from there. And what happens is that may take, maybe a minute to go from AP to lateral to get that shot, maybe 30 seconds. But that saves you time so that you don't continue to progress the case in the wrong spot, only to find out that you're wrong later. So when we talk about being fast in the R, what we're really talking about is being efficient. Is Meng, are you mic'd up in the lab yet?
We can probably start.
It's mostly this. There all is. So we, came up with this short kind of summary of the transforaminal approach. I think there's some very clear benefits to it over other approaches. I think it's a very easy approach to adopt for awake procedures. I think for the transforaminal approach, it's likely the least destructive in its surgical approach compared to interlaminar or even biportal. And then I think it's a great surgical approach for revision surgeries, as we've heard and demonstrated through presentations yesterday. I think the one thing that is a little bit difficult, or one of many things that could be difficult with the transforaminal approach, is the targeting, and that's why we wanted to start with this one. It's a little bit more challenging. And once you get down and you target what you think you're trying to get to, it's then understanding the anatomy, because we're not used to seeing the anatomy from a lateral view or from the transforaminal view. We're used to seeing it from a top-down approach. So understanding where you are means that you have to first understand the anatomy and understand what it was you were targeting, and look for small little minute clues to confirm that you are where you think you are. So this is a kind of recap of yesterday's presentation that Meng gave, and pretty much you can see that the interlaminar window, as you start at L5S1, it's really wide, and as you go further up that, the levels in the spine, the lumbar spine, it gets more and more narrow. Whereas for the transforaminal view approach, it's the opposite. Whereas at the higher level in the lumbar spine, the interlaminar or interpedicular distance is larger, and it gets smaller as you get down lower into the spine at L5S1. So for that reason, L4 and 5, L4, L5 and above is a great approach for transforaminal surgery. It can be deployed at L5S1, but those are very specific cases that can be very challenging, especially if the iliac crest is in the way. So some anatomy, again, when you're looking at Cameron's triangle, you want to know the borders of it, and really we're thinking about this more so in a prism. But you can also maximize your transforaminal window by removing some of the, superior articulating process. And in some situations, if you have a caudally migrated disc, you might even remove a little bit of the top of the pedicle, which is completely fine. So we'll pause here so Meng can kind of get things set up. Meng, can you hear us?
I can hear you. Can you guys hear me?
Yes.
There we go. All right. Okay, so we'll go ahead and get started here. I think that slide is pretty important. It's the concept of the spinous process plane. So let's go ahead and come in and take a look at the cadaver and get our markings set. So, John, I'm doing L4-5, right?
Correct.
Okay. So let's focus in on L4-5. Ooh, scoliosis, excellent. Okay, so let's try and get a.
We did not want to make it easy.
Yeah, you didn't want to make it
for
easy
you.
on me. Okay, so let's tilt towards the head. Let's take a shot. Yeah, a little bit more. I guess I don't suppose there's any way to rotate the bed, huh? No. Okay. All right. That's okay. Okay. That's great. So, and then let's center up a little bit. And then can we arc towards you?
So, Meng, quick question for you.
Okay.
Can you hear me, Meng?
Kind of reasonable. Wait, why don't we arc towards you a little bit more?
May we have a question from the audience?
Meng,
Yeah.
is it something at this point right now that you would use the arch of the
Actually,
scope?
come back towards me. Sorry, I didn't hear that. Say that again.
At this point right now, you're changing the arch of the C-arm. Would you recommend that, or would you rather rotate the patient?
I asked if we could rotate the bed, and we can't. So unfortunately, we can't rotate the bed. But yeah, to your point, I typically always keep everything true AP and true lateral, and I just rotate the bed and not the C-arm. Why don't we come back towards me a little bit more? Towards me, arc towards me. Yeah.
So what the audience, hopefully what you're seeing is that, in this kind of constrained setup that we have, rather than, settle for a worse looking x-ray, he's really trying to line up the end plates and get a true AP view. So he's going to be doing some trigonometry in his head to figure out exactly how to make his angles work for this,
let me control it?
which is honestly a marvel in itself.
No, just the arc, yeah. Let's take one more shot there. Maybe a little bit more. A little bit more. Wow, there's a lot of rotation here. Here, let's take another shot there. Okay, I think that looks about as good as we're going to get. So, as John was saying earlier, the biggest thing is you have to have a perfect x-ray, right? Perfect AP, perfect lateral. And then the end plate looks pretty reasonable here. There's quite a bit of rotation, as you can tell, but the pedicles look probably the best that they look based on this picture. I usually mark out the vertebral body of the disc of the body below. So let's take a shot there. One more shot there. Okay. So this marking, usually I use that as a reference point for the radiographer to look at the WAG, how much WAG should be done once we go lateral. And then I'll mark the midline as well. Let's take a shot there. Okay, one more shot there. Okay, one more there. Okay, one more there. Okay. And then also, can we slide towards the feet a little bit so we can center up? That's another point, obviously, let's slide back up. I want you to put L45 right in the middle of the picture to eliminate all the parallax possible. Okay, all right, so once we get this line, then I start to think about my trajectory. So let's see where this pedicle is. Shot there. One more shot there. Okay, so can you guys also see the surface of the cadaver too? Let's see a shot there.
Yeah, we can see the surface.
Okay, so I'm gonna just kind of draw out the silhouettes of the pedicles. So for example, if I'm gonna go for, say, a caudally extruded disc herniation, then I know that my angle needs to be something like this, right? And then I'm gonna take away some of that pedicle. Conversely, if I'm going for a cranially migrated disc, I'm gonna take a more flat trajectory. And all these endoscopes are about 20 to 30 degrees working angle. And so you can really look around the corner. And so again, the key is we want to get to basically the medial border of the pedicle below and the posterior vertebral body. And typically you take a little bit of a cranial caudal trajectory, and that's how you stay away from the exiting nerve root.
So Meng, quick question here. Allude a little bit more towards what you can reach and what you cannot. So I love that you think already about migration and stuff, but where are the limits and what levels can you use this technology or this technique, and where does it not work?
Yeah, so that's a great question. So as far as migrated disc herniations, I find that typically, we normally take a cranial to caudal trajectory. And so when we do that, we can easily take off the top of the pedicle below, and it's really just maybe 2 or 3 millimeters. So it's not like you're destabilizing the pedicle. But that allows you to really look around the corner, and then with the angled instruments, you can grab those down migrated disc herniations, even down to nearly the level below. So we're talking about zone 3, zone 4 migrations you can access. I would say zone 2 you can easily get to when you go cranial, but it's actually a lot more harder to look up once you go through the foramen. And I think the zone 1 behind the pedicle of the rostral level, that's really hard to reach because it's really actually hard to see up there, and you're taking blind grabs. So I would say zone 2, 3, and 4 are the limits. As far as the level of the lumbar spine, L5S1 becomes harder, especially in males, because of that iliac crest. So you have to kind of determine, based on the individual anatomy, whether or not you think you can access that. So if we draw a standard trajectory on this, let's take a shot there. So one more shot there. So you can see that basically I'm hugging the ipsilateral top of the pedicle.
So Meng, another question is here right now. A lot of people are wondering what angulation you take there, and I've had hours and hours of discussions with other surgeons, how many degrees and how to get that inclination. So what is the solution to this, Meng? You're on the spot here. How do you determine, besides the pathology, but let's say you have a non-migrated disc, how do you determine that inclination?
So the inclination, basically, I just determine this on where the pathology is. So if it's non-migrated, and I know the scope has a 30-degree viewing angle, then roughly this trajectory, which is about 30 degrees, will get you a straight-on view of the disc. And then I just adjust that accordingly. So I don't really build any specific guidelines as far as angles. I just kind of go based on where I think I need to be for the pathology. So that's not a very scientific answer, but that's my answer. So for example, this would be a very standard trajectory. So you see I'm crossing the top of the pedicle on the ipsilateral side, and then on the contralateral side, I'm crossing the bottom of the pedicle. And I think this is a pretty safe trajectory to use to access almost any disc herniation. And so I'm going to draw my AP trajectory line here. So this is going to give me a visual clue and guide me towards the spine once we actually do the approach. So at this point, what I typically do is I go to the lateral, and now we're talking about the, so let's go to the lateral. Now we're talking about that spinous process line.
So now you also have to make sure that you don't have a orthogonal image, right? An orthogonal image, and sort of tilt that too, right? So that's the problem right now with the cadaver not being, straight to the floor, right?
Yeah, and that brings up a good point. So, we had to arc the C-arm quite a bit to get that AP view. So we know that we're actually a little bit rotated like this. And so it's going to be hard to get a nice shot of the actual level. So let's take one more shot there. Okay, I think that's probably the best that we're going to get.
So while Meng, while you're getting your trigonometry on here,
Yeah,
we're
yeah.
gonna just
Yeah.
quickly switch.
I don't
back
think
to
it's the wag so much
we
as
switch back to the presentation.
yeah.
So just for those in the audience, you can
Okay,
see
that's
what he's
fine.
trying to do is identify a starting point for his incision, and he's looking to have his instrument in line with the plane
Exactly.
of this
So what I'm gonna
spinous process line, so the top of the spinous process. And so he's now essentially trying to get his C-arm to be a direct lateral, which is hard for this scoliotic patient. But surprisingly, he is, crushing this with very little tools. He's MacGyvering it pretty well. Let's go back to the lab.
All right, so this is what I was talking about in the lecture yesterday. So what I do is once I make that AP trajectory line, then I just take the tip of my instrument and I just walk it laterally on here. And then so this is a very skinny cadaver, right? So you can feel the spinous process right here. So I know I'm already at that plane. So we'll take a shot there. And so you can see that the tip of the instrument now is at the plane of the spinous process. And when we talked about earlier and with the slide up on the actual talk,
Hey, man,
John
can
is.
you use a different instrument? We were not able to see that on the X-ray.
Yeah, we can use it. You can use any instrument that you
Use
want.
the pusher. The pusher works
Do you have a
really
regular
well.
spinal needle?
Give him the yellow or red pusher.
Yeah, I mean, you can use essentially any instrument that you want here. So you could do the same thing. So if you were doing this traditionally without this long Jamshidi needle, let's take a shot there. You do the same exact thing, right? This is
The image is a little washed out. Maybe they can change the
Can we
contrast.
increase the contrast? No, that's fine. That's fine. No, that's fine.
Other way.
Let's take one more shot once we get the contrast better.
there we go.
Can you guys see that?
Yes, now
Yeah.
you can see it.
Okay, so let's take one more shot there. Okay. All right, so you'll see this better here. Let's take one more shot there. Okay, so again, so the plane of the spinous process is right here. So this, just based on that, that's where my starting point is going to be. So we'll make a little incision here. And then there's a couple ways you can target. You can target on AP, you can target on lateral. This particular approach is the trans-SAP approach. So I know I'm docking on bone, so I typically actually do this on the lateral instead of the AP. Let's take a shot there. Okay, so now what I'm doing is I'm visualizing again that AP trajectory line that I drew earlier. And so I'm just gonna go follow that trajectory towards the spine. Obviously, you want to stay shallow to be safe, and then you can always pull back and redirect, right? So let's see a shot there. Okay, so I'm touching bone right there, so I know that I can actually steepen my hand a little bit. Shot there. Okay, one more shot
And Meng,
there.
how much are you relying on your tactile feedback to help you guide your instrument?
A lot. I mean, that's the thing. You got to feel for the bone, and then utilize your X-ray at the same time. This is going to be a bit of a challenge because of the rotation. See a shot there? And then, actually, do you mind flipping the C-arm? One thing I like to do is I like to flip the image to the orientation. So the head is to the left, feet is to the right. And then can you turn this 90 degrees counterclockwise? Yeah, just rotate the image counterclockwise. There you go. Okay. So now I can sort of visualize this better. And let's take a shot there. Okay, so I'm on the facet joint. Shot there. Okay, I'm going to slide off. Let's see a shot there. And that feels like I've slid off into the foramen, although this image is really hard to tell because of the rotation and we can't turn the bed. Shot there. Okay. So I'm going to assume that that's the facet joint. One more shot there. Feels like it. So it's really unfortunate that we have such a significant rotation on here because you can't really see the fact that I'm docking on the ventral SAP very well on the x-rays.
Would there be any, I mean, it might be too late, but any way to prop up the cadaver a little bit?
What's that?
To prop it up with some, you know,
Yeah, I mean, if we could prop this side, that would help, I think.
Meng,
Can we go back to the AP?
What's that? Yeah, I think we need to rotate this way. Towards me, yeah.
Man, can we go back to that AP while you prop it up? I think that might help get you a good true lateral.
Let's just take a shot there and let's see. Let's take a shot there. Can we take a shot? That's much better. That's better. One more shot there. Yeah, something like that.
Meng, I think this is a really good example how important the X-ray is. Do you guys see that? He was in the back of the facet joint. So getting this perfect X-ray, AP X-ray, you know, almost threw him off, but thanks to our help.
All right. That's awesome. You gave me a scoliotic level with a grade 2 slip. That's fantastic. Thank you. One more shot there. Okay, that's better. Let's try and wag it a little bit. This way, maybe? Yeah. And then slide the machine throttle. You gotta lock the light, yeah. Shot there. Okay, that looks better. Let's go take one more there.
Do you want to get a quick AP too? Like
That's
John's
pretty good. Okay, so slide back up.
Do you want to get a quick AP?
Yeah, we will. Shot there. Yeah, because this looks, this is, I think, about as good as we're going to get. Okay, so let's get back to AP. Where's the mallet? Thank you. Is this a straight AP? You're at 0? Okay. Let's see another shot there. Okay. Let's, why don't you arc that way a little bit more? Yeah, one more shot there. Okay. Yeah, I mean, you know, it is what it is, about as good as we're going to get. Let's go back to lateral.
But that's a much better AP, right? Did you do a lot of arch or not?
Not much. And I think, you know, the take-home point is, you know, you can't settle for parallax imaging.
And
I think
bring the
part of,
machine down
you know,
a little bit.
The struggle here is that this significant scoliosis patient or specimen, you know, is challenging to do without having a table that we can rotate.
Let's see a shot there.
But now you can see the SAP, right?
SAP
The
a little
pathology.
better.
Shot there.
Point out the SAP on the screen.
I don't think it works. But this is
One more
this is our
shot.
SAP right here, and he's essentially docking. You can see a little bit of the whack. Can we lighten up the contrast maybe a little bit on the X-ray image?
One more shot there.
You can faintly make out the foramen here, the arch, and this is coming up from pedicle to SAP right here.
Yeah, it's still a little bit hard to tell, but much better. Shot there.
So, Meng, you want to share with us what's going on in your head right now? Because in your head, you're right now triangulating.
Trigonometry is going on.
So basically, I'm trying to target the base of the SAP and the pedicle junction. I think we probably started off a little bit more lateral than intentional because of the original rotation. And so we're coming in at a very flat trajectory. So what I'm feeling is that essentially I'm sliding directly into the foramen. Let's see one more shot right there. Yeah, this is going directly into the foramen because of the flat trajectory. That's okay. Let's see a shot there. So what I'll do instead is I'll kind of target more on the actual pedicle. So let's take a shot there. Okay. One more shot there. Shot there.
So, Meng, can
One more shot.
can you explain to the audience how you're picking that starting point there? Because I'm sure people are wondering right now. You want to get into foramen, but you're really in a facet joint.
Say, I can't hear you. Say that again.
Can you explain to the audience how you're determining the starting point on the facet joint right now? Because you're not getting you're kind of getting away from the foramen rather than getting into the foramen right now. What is your thinking here?
So basically what's going on is that I started, the starting trajectory was too lateral, and so I'm very flat, and so I can't feel the SAP because of the fact that we started so lateral due to the rotation, and so I can't really dock on the facet. I'm basically going straight into the canal here.
Why
if I
don't you
dock
make
on the
another
facet.
incision?
We could redo this. Let's see a shot here. Okay, so again, we're on the spinous process. So we could try a little bit more of a medial starting point. Let's just see that spinal needle. Okay, so one more shot there. Okay, so we're still on the spine. I'm going to take another shot here. Let's see a shot there. Okay. One more shot there.
So, Meng, in a regular case, you would probably use this trans-SAP approach for someone who has a really tight
Shot there.
final stenosis. In this case, with this
One more
scoliosis and maybe even a little bit of a spondy, is it always necessary to do a trans-SAP, or as it looks like you might have a window to get your scope in through the frame? And
Shot
is that
there.
something that you might just pivot to, just doing a transforaminal approach?
Yeah, and that's exactly what we're doing. Shot there. I think that's a good point. You don't necessarily always have to go trans-SAP. I like it just because it kind of guarantees me that trajectory through the ventrolateral SAP shot there. But you're right. This is not a huge foramen. I mean, this is not a super small foramen, even though there's a slip, and so you could do a regular access as well. Take one more shot there. Why don't we get an AP and just kind of see where we're at there? But I think the benefit of the trans-SAP is, you have a rigid instrument, there's not a lot of bend to it like the needle, and so if you are targeting that ventral SAP, you'll get exactly where you want. Can we turn this image back 90 degrees? Just straight, just upright, basically. Okay, so let's see a shot there. One more shot there. Okay, so I've hit bone there. So with the standard needle, you do want to do this on the AP when you're advancing through the foramen. Why don't we tilt towards the head too, quite a bit? Again, going back to the basics of having a perfect X-ray. Let's take a shot there. There you go. Okay, so now we can see the end plate a little bit better, and you can see that the tip of the needle is basically at the medial border of the pedicle, and I'm touching bone, which is the posterior vertebral line, so this is a good landing zone. So let's go back to lateral and check that on the lateral.
Meng, can you hear me?
Yes.
It's Sanjay. I think it's important to know what you did there, right? Like someone asked a question about redefining failure, and we had a good conversation about it yesterday during the question time. But what Christoph suggested of changing that incision, that's okay, right? I mean, you have a small sub-centimeter incision. If this is your first case, and first of all, it shouldn't be, right, with the spine. But if you're having issues getting to where you want to be based on your initial incision, make another one, right? And that's part of the patient discussion. That's part of everyone sort of being in your room and having buy-in from all the folks in your operating room. You have to be able to just like bite the bullet, just make another incision. So
Yeah, absolutely. I think that's a great point. I mean, it's no big deal at all to make another incision like this.
Can we quickly switch over to the presentation? So just for the audience, it's a little bit hard to see what Meng has just accomplished I'm not sure why there's an emoji thing in the front.
Let's see another, let's tilt back to where we were. We need to maintain that tilt.
What you can see here on the monitor, what Meng just accomplished in this scoliotic, specimen was he landed his spinal needle here on this posterior vertebral body line.
See the first
and he
guy
has his, on the AP, he has his spinal needle right here on this mid-pedicular line, which is what we're targeting. Initially, he was trying to do a trans-SAP approach, which proved to be a little bit difficult because one, the foramen was pretty large. And then two, also the angle and the rotation of this cadaver didn't give us a really good picture. And despite best efforts trying to get a good true lateral and true AP, it gave us a little bit of a starting point. So to Sanjay's point, there's nothing wrong with starting, picking a new trajectory. But at the end of the day, you want to confirm that you are where you think you are, that you are aiming for these two specific targets on AP and lateral. And then once you get that confirmatory tactile feedback of bone, you can then progress to whether reaming or sequential dilation to the target area.
Yeah, so that's a good point. And then here what we're doing is we're starting the reaming process. And so I've docked with that needle. I changed it out for the guide wire, and then there's a sequential dilating process, right? And so let's take another shot there. Okay, so at this point, I've got the first crown reamer in. I'm feeling bone. And so what I'm going to do at this point is start the reaming. And so if you look at my hand, I'm applying all my forward pressure with my left hand, and I've got it stabilized on the body so that I can't really plunge too much. And so my right hand is really just rotating the crown reamer. Most of the force is being applied with my left hand. Shot there. That way you can sort of avoid over-reaming, if you will, and plunging into the canal. So now we're approaching that medial border of the pedicle. Let's see a shot there. And you don't want to go beyond this line, right? Because this line obviously means that you're in the spinal canal. So I'm going to stop there. And then we're going to take out, and then
just to kind of elaborate on your approach, you said you're pressing a little bit downward pressure. As you're holding with your left hand, are you giving any pressure to the SAP by kind of pushing your hand a little bit down towards the ground to kind of more engage the SAP, or are you just putting forward pressure?
Yeah, that's an excellent point. So let me just pause for 1 second and just show you this crown reamer. I don't know if you guys can see this, but the way these reamers work is that they don't really cut when you turn counterclockwise. They only cut when you turn clockwise. So as you're putting this in, you generally go counterclockwise to get through the soft tissue, and then once you land on bone, then you can start the reaming process. And then going back to your question, so at this point, what I'm doing is two things. One, I'm applying a forward pressure, and then two, just as you alluded to, I'm applying a little bit of a downward pressure to lever into the SAP. So let's take another shot there. Okay. Let's see another shot there. But one more shot. Okay, great. So now we're going to go up to the final dilator. And then we'll get the final reamer. Yep, no problem. That's actually a common thing that'll happen, is that one of the dilators will get bound up by bone in the reamer, and then it'll come out, and then you just have to put it back in. Sometimes it actually drags your whole system out, including the guide wire, so you just have to retarget. There's not much of a way around that. See a shot there? Okay. So why don't we take a lateral just to get an idea of what we're looking like? So at this point, if you're doing this in an awake patient, then what you're looking for during the reaming process is any feedback into the leg. They're always going to have back pain when you do the reaming if they're awake. But if they tell you at all that they're starting to feel pressure in the glute or the leg, that's when I sort of back off and reassess and look at my imaging and make sure it makes sense. So this is a good picture so far. We're already fairly medial. You can see that we're about at the mid-pedicular line, and we're still very much posterior to the posterior vertebral line. So this is a good spot. So let's go back to AP. And then if the patient is asleep, then I typically have free-running EMG to see if we capture any spontaneous discharges. let's see a shot there. Okay, so we're gonna wrap up the reaming. One more shot there. Okay. Shot there. One more shot. Okay, so at this point, I'd be comfortable stopping here. If you look on the fluoro image, the reamer is almost at the medial border of the pedicle. I think with the larger reamer like this, that's more aggressive. You can certainly start to back off here and finish with the reaming process. So we'll take the final reamer out, and then we'll put the working channel in. See, this working channel, is this the... This is the regular one? Okay. This working channel, you can see, is beveled. And so this bevel allows you to do several things. You can actually get underneath the traversing nerve root and land on the disc. Thank you. So what you can do is you can actually land on the disc and retract the traversing nerve root. If you're working outside of the foramen, you can find the exiting nerve root and rotate it out of the way. And generally, when I'm not sure that this makes a huge difference, but as a rule, I typically, when I put these in, I put it with the bevel facing the root so that we can glide past it. So assuming the root is coming in this way, I'm going to put in my bevel like this, bevel open to the root, okay? Once I'm past that on bone, then I rotate, and let's take a shot there. Okay. Take one more shot there. I've taken out my dilators. So now you can see that the tip of the working channel is at the medial border of the pedicle, so we know we're about to look into the canal. And then let's get a lateral just to confirm and make sure that we're not inside the disc space. Okay, so that's perfect. So the tip of the cannula is still posterior to the posterior vertebral line. And so at this point, you're ready to put the scope in and start looking at everything. So is this where I stop?
Great job on that very difficult targeting approach, Meng. We're going to now transition over to Saqib, and we're going to do targeting for the interlaminar approach, which will be at the L5 S1 level.
Saqib, don't take that transforaminal port out. We're going to need that one.
Can you guys hear me? Okay.
Can we switch over to the presentation?
It's too.
So for the interlaminar approach, there are some pros that we identified, and I would say probably one con. For the interlaminar approach is a very familiar approach because if you do any kind of MIS or tubular work, the anatomy is very familiar to you. It's a top-down view that you're used to seeing through tubes. It can be a bone-sparing approach, even if you're using the interlaminar approach for L4, L5 level. The amount of bone resection that you have to do is usually very minimal. You're usually just taking the undersurface of the cranial lamina, and at some point a little bit of the medial facet joint, so usually no more than a few millimeters. It has the widest application. It can be used in the cervical, thoracic, and lumbar spine. And then, of course, I would say that the con that we've kind of agreed on is the scope handling. So a lot of people find it difficult to manipulate the scope to do what they want in the interlaminar approach because you're kind of working inversely. So when you want to look up, you have to move your hands down. When you want to look down, you have to move your hands up. So, but with that, I think we can kind of progress to the targeting.
So John, you can keep going because we're gonna actually, Meng was a real trooper and he used that last cadaver, but for the sake of all the attendees today, we're gonna change the cadaver to make it a little bit easier to follow on X-ray.
Okay.
Thank you, Meng, for taking one for the team.
Yeah, so when it comes to targeting for interlaminar approach, pretty much it's the same concept. You want a good AP X-ray. You can use some lateral X-rays for interlaminar, but honestly, most of the targeting is done in the AP. You can see in this slide here that in figure A, we start off with a true AP through the disc space of the index level, and then we're going to tilt the beam of the C-arm a little bit caudally towards the interlaminar window. And what you're seeing is that you go from having the spinous processes kind of over the disc space here to it slowly moving up and over the disc space. And that's how you maximize your interlaminar window. And that technique is very important because when you target, you want to use the maximum width of that interlaminar window. At L5S1, it's really large. At L405, it's just ever so smaller. And maximizing that window will help reduce the amount of bone you have to remove, if you have to remove any bone at all. And then, of course, depending on where your pathology is, that is where you're going to, how you're going to change your actual targeting approach. So for a non-migrated disc herniation, it's typically just a true interlaminar approach where you don't necessarily have to make significant adjustments to your cranial caudal targeting. For a caudally migrated disc approach, you kind of want to start more in the bottom of the foramen or bottom of the canal, and essentially you're targeting. Therefore, you're targeting a little bit higher up in the interlaminar window so that you can look downward and find that migrated disc herniation. And then if it's a Rossi migrated disc herniation, your incision is going to be a little bit more caudal, and then you're going to have a steeper inclination to kind of look up towards the cranially migrated disc herniation. And in either situation where the disc herniation is either cranially or caudally migrated, you're going to have to remove maybe to some degree a little bit of bone so that you can actually get your instruments and your scope in to that area of the pathology. So we'll pause here to see and check in on the lab to see where we are. Still switching the cadaver. Any questions from the crowd?
What's the faculty's experience with doing transforaminal approaches in scoliosis patients? We see a lot of these patients who have isolated radiculopathies either on the convexity or the concavity of scoliosis, and often that open foraminotomy leads to a scoliotic revision at some point down the line. So is a foraminoplasty a viable option instead of doing the multi-level T-lift or whatever?
Yeah, I think it's definitely, especially if it's a monoradiculopathy, it depends on where it is, right? If it's in the concavity, you have to be careful because oftentimes you'll decompress that area and then it will collapse even more. And that's a sign that the patient's unstable there. You probably need something more than just a foraminoplasty. But if it's on the convexity or if it's just lateral recess stenosis, you can use maybe even an interlaminar approach so that you're not taking too much down of the SAP and destabilizing that joint. So it maintains the integrity of the height of that foramen. Any other faculty have thoughts on that? Or?
I think honestly, even sometimes for the right patient, I think, is this working?
You can hear you.
Okay. Yeah, so for the right patient, I think even in the concavity, it could work. It just has to be the right patient. You have to just let them know, because it's, again, like redefining failure. Even if it fails and you get maybe a couple of years of relief, that's not really a failure. So I think it works for some people. I think when, in terms of, the question is whether the stenosis from top-down stenosis, like between the two pedicles, versus if there is a lesion in the foramen, whether it's buckling of ligament or disc that's causing the problem. I think it works. I think if it's up-down stenosis, then might not be as successful, even if you drill the pedicles.
Yeah. And again, just to kind of the whole purpose of endoscopic spine surgery is, the least invasive approach. I think the one thing that we haven't really touched base on is that this doesn't limit other approaches. So if you do the least invasive approach and it works for 1 year, 33 months, 6 months, however long it works, well, you save that person from having to have the more invasive surgery for that time frame. And if they need to go to that bigger surgery, you've at least gave them the option of trying something less invasive first. And many patients are appreciative of that.
Yeah, I think sometimes you're very surprised. I mean, there are patients with bad, like you're at the apex of the scoliosis. I can think of a patient of mine who's 80 years old, apex scoliosis, definitely would need a multi-level fusion. I just told him, let's just give this a shot, and did a 2-level foraminotomy, and sustained improvement, honestly, years later now, like just 2 years, I think. So I think you're surprised sometimes, and as long as you counsel your patients about the risks of it potentially not working, and the fact that you're not burning any bridges, I still think it's a good surgery to start with.
I totally agree with that.
Right, for scoliosis with the concavity or fractional curve with foramen, if it's very, very tight, I usually do not use a reamer. I use endoscope. I do my foraminotomy with high-speed drill. So everything will under direct visualization. You usually start more dorsal, and So that way, you guarantee you're putting layer by layer, make sure it's safe. So that's just for extreme cases, like concavity or fractional curve.
And how often would you say that you're getting patients who come to you specifically for this kind of radicular pattern in the concavity of a scoliosis? Is it something that's very common? Is it something that's comes once in a while? How would you describe it, its occurrence for you in your practice?
Probably in between. There's certain patients, they know, they have seen several other surgeons. Everybody recommended multi-level fusion, but they just have a selected radiculopathy. They really do not want any fusion. So they will come to you. They say, I just, have this lateral leg pain. You just do a L5S1 foraminotomy, I'll be happy. So you actually, as you do more and more, you will see more and more patients. They just come to you. They do their internet search.
So it sounds like, in effect, you took a patient who was completely against surgery and then made them surgical.
That's true.
Yeah. So you think about it, you've opened a whole nother access to patients who initially did not want surgery, who are now looking specifically for targeted surgery. So you're offering care that was otherwise not available to them. So you've accessed a whole nother group of patients, which is quite amazing. You apply that same concept to patients who are morbidly obese or extremely old and frail, right? But they just need a little bit of more quality of life for the rest of their life. You're giving them another option and, to some degree, some hope that they might have some pain relief. So,
and the nice thing too is that you could do that procedure with a tube, but I have a patient specifically where I did one level with the endoscope and one level with the tube, and the level done with the endoscope and the level that was done with the endoscope has, like, the radiologist couldn't even read that there was a surgery done there. So I think that's the benefit of using an endoscope rather than a tube for these cases, is you disrupt the facet joint a lot less. In my experience, it's clear. Like, there was definitely one level where it was done with the tube, the top of the facet joint's messed up, and the lateral pars is drilled, and then you have the endoscope where you can't tell that any bony work was done. So I think in these cases, if you could safely do it with the endoscope, it is better than doing it with a tube.
Saq, how are we looking in the lab?
John, can you hear me?
Yeah, we can hear you.
Okay, perfect. All right, we're ready to go.
Excellent.
Okay, so, we talked about the interlaminar technique, and, it is kind of the workhorse for posterior-based surgery, kind of the same idea what Dr. Yoon's going to talk about for biportal. Where's the camera? Right there. So you can see that we now have a normal cadaver, so it should be a lot easier. Bottom line is, this is a very easy targeting in terms of getting there. Transforaminal is a little bit more complicated, because transforaminal, you are essentially coming from an angle. But over here, our principal anatomic landmark is this inferior medial edge of the lamina, if you guys can see here. I'll turn it there, yes. So essentially, you are picking, depending on who's doing it, you can pick a lot of different areas in this interlaminar window. Generally, I like to pick this area right here. And if you're going to be going for a ULBD or over-the-top decompression, it's better to kind of be up here, because you want to go undercut the spinous process and go around like that. So what I'm going to do today is it's very quick. We're just going to show you how to target down there. And the key features, which John probably pointed out, are imaging, palpation, and visualization, which is what we're going to show. And I think the other guys are going to show the visualization part. So let's start with an X-ray here. So let's take an X-ray. So the first thing you want to do is, I know when Meng talked about it, he kind of got a square end plate view. You don't actually want that for interlaminar. You want to see the interlaminar window. So let me see the marking pen right there. So you can see, take a shot there. Let's go down there. We'll do 4-5, shot. Meet in the middle, shot. So I'm going to walk it out a little bit lateral right there, shot there. Oh, right there, shot. Okay, so I like that starting point for a ULBD. Now, if you look here, if you cant the X-ray and kind of angle that way a little bit, about 5 degrees. No, the other way. Yep, take a shot there. And then come south a little bit. You see how the interlaminar window is opening up a little bit. Okay, shot there again. Okay, now go 5 more degrees.
Just to clarify, Saqib, you're using 4.5 because we're going into tissue handling and bone drilling after you want to optimize that to make sure that they have enough bone to drill on the next steps, right? So I think
Exactly.
it's important to clarify that, if you're going to do your first L5S1 or, if, interlaminar, it's probably going to be L5S1 where that huge window is in the bottom, but you're purposefully going up here, right, for your
Yes.
interlaminar demonstration.
Yeah, we're all trying to work together. So if I target here, then they can then use this area later for their bony decompression. So 4.5, it's a lot of bone, a smaller window than 5.1, like you said. So we're going to start here at 4.5, and then hopefully the other guys are going to be able to do a nice decompression. So take a shot there. Go a little more, go 5 more degrees. You see, as I cant the angle of the fluoro, you can see the window opens up more. A shot. And you see less of the spinous process. Every time you do that, come south a little bit, please.
So just for the purposes of the audience, in most of these cases, you're doing this on a Wilson frame as well, right?
Yes, exactly.
So that would help open and maximize the interlaminar window.
Yes.
And you can even see on the X-ray comparing the L4-5 window versus the L5S1 window. The L5S1 window is almost twice as large to the L4-L5 window.
Exactly. And you see, as I canted the X-ray, I was able to kind of open the window up and see less of the spinous process. Now, just for sake of showing the opposite angle, I'll go back to neutral now, and you'll see, and as you come back to neutral, and take a shot again, you'll see the window's changed again. Shot. Come back up north. Yep. Kind of meet in the middle, right there, south. You see now the window is a lot smaller, and my starting point is lower now. So shot there again. Okay, up there, shot there, and shot there. So you can start anywhere along the interlaminar edge, but for the sake of, can you guys show the angle right now? Now it's neutral. So the big thing I like to focus on when I'm doing this is, for the orthopods here, when we're putting the freehand screws in for different parts of orthopedics, we kind of be the beam. So you see the beam right here is, if I use an angle right here, take a shot there. Right there again, shot. Sorry, right here, shot. If I take this and I just go straight down with my needle, I have to go straight down with the X-ray, and then I'll land on that lamina. But if I go and give me that angle again that way and then come south, so we're gonna, no, the other way? Yep. Shot there. Yep, exactly. Okay, so that window's bigger now, so I'm gonna take this one now. And shot there. Right there, shot. So I'm gonna mark that. I like that edge right there. So I'm gonna mark this here. Okay, knife.
So while he makes that incision, can we quickly switch back over to the presentation? So just to kind of bring home the point, you can see that in this slide, what he's done is he's identified that interlaminar window and is now following along the edge of that ventrolaminal surface at the cranial level. And he's essentially maximized his approach to that window. And now he's gonna use the C-arm beam to actually target that same area where he marked on the AP. So it's important to make sure that your incision and your probe for dilation is actually going the same angle of the C-arm, otherwise you'll be off.
Okay.
And so you can see this is kind of the steps where he's at now. He's making his incision with the 11 blade, and then he's going to use multi-step dilators. And when we move to the point of having the endoscope brought in, we're going to actually want to then visualize and complete that trifecta of targeting, palpation, and visualization, and see that same thing that we targeted, which is that inferior edge of that lamina, that kind of smooth curve. We can go back to Sock in the lab.
Okay, let me see that blue handle thing. I just want to see. So one thing that you guys have to pay attention to, take a shot again real quick. It went down up there, right there. Shot there. Okay, so you can see that my instruments are parallel to the beam of the C-arm. So shot there. And if I go a little bit more like that, shot. That's kind of the window where I want to be. Do you guys kind of all see that? So I went from that inframedial edge, and now I'm palpating. I'm feeling my, if you see my hands, they're falling off that lip of lamina here. And then while I'm doing that, I'm also doing some blunt dissection. So you can see as I put the next size up here, again, I'm feeling the dip off, the fall off the lamina there. Okay, and then let me get this guy here, and take a shot there. So you can see, angle again, shot there. That's my starting point, right? So when I put my endoscope in, the first thing I'm gonna see is that bony ledge. And let's just, for the sake, we don't have the endoscope set up right now, or we do? Yeah, so just to show you my blunt dissection and what I got, you see when I put the bevel in, I put the bevel in facing me so that this edge of the bevel is sitting on the bone. So I'm not skiving medial into the ligamentum flavum. I'm kind of on the bone, kind of docking like this. If you see here, I'm docking kind of right here. That makes sense, on the edge. So if we get the endoscope in, we can just show where we are, and then that's pretty much the interlaminar approach. And we talk about the imaging, palpation, and visualization. That trifecta is pretty much the basis for all endoscopic spine surgery. You have to use fluoro to kind of localize where you are, use your hands to confirm that you feel bone, because bone is home for the orthopedists, and then visualization is the last part. So we're gonna put that down, and then we should see some bone right here, and we're gonna let the guys talk about soft tissue dissection, but if I just take a little bit of pituitary right there, pituitary, you're gonna see bone right now.
So let's leave some of that for them
Yeah.
to talk about.
Sure.
Yeah, but we
Okay.
believe you that you did the targeting.
Okay, perfect.
Thank you.
All
So
right.
now we're going to switch over to Jon Yoon. He's going to talk about biportal techniques. And I will admit I'm a little bit biased against biportal because I haven't quite picked it up, or maybe don't plan to, but we'll see. But I do think there are some pros to it. It's efficient and quicker surgery for people who want to do surgery a little bit faster in multiple cases. I do think that it's easier to adopt. You don't have to worry about trying to utilize a working channel in the scope. Because you get to use two hands where you're looking at your instrument and then also are able to have 360 degrees use of that scope and your instrument. But I would say that one of the cons is limited applications. Again, as someone who doesn't use it, I don't have a lot of experience in all the different applications of biportal endoscopic surgery. But I would say that you probably can only really do top-down surgery, and maybe in the cervical, thoracic, and lumbar spine, you can't really do much of a transforaminal approach. And then one of the other cons that I identify is that it's more destructive. So you're making, two incisions, and one of your instruments is working in the tissue planes, kind of unsheathed, and then the other instrument is a camera that you're having to develop a pocket so you can have your camera sit and actually give you a pocket to work within a working space. So with that, we'll let Jon take it away and show us the targeting for biportal endoscopic surgery. We can't hear you. Your mic's not on.
Is the mic on?
There we go.
Is it on? Okay. Hey, everybody. So the biportal, I think the targeting will be very straightforward. Let's take a shot here. We have probably a 4-5 still, right? Still intact? Okay. Let's try to do 4-5. So it started with the same thing. You do want to get a shot center around the disc space, and I will tilt the angle of the C-arm to get a very good AP. So yeah, do maybe a little bit and take a shot there. Center that. And come down caudally towards the hip. Do you have some marking pen? No. I like that angle. Keep that angle. Actually, no, go the other way. I'm sorry. Go the other way. Good. And then let's take a shot there. And come down towards south, towards the bottom. Okay, so that's a 4-5. Do a little bit more angle of the tilt this way. So it's a 4-5, usually lordotic. Okay, that's good. Okay, take a shot there. Everybody running into the table there. And maybe pull towards you. Okay, maybe I go now cranial, just, no, that's too much. Come back down a little bit. Take a shot there. Now try to do a little bit more tilting if you can. So you want to start with the perfect AP and try to do more tilting this way so that the top of the intermediate, okay, that's good enough for cadaver. So that's good. Try to take a shot there. Okay, so that's the, no, it's okay. I think this is good enough for cadavers. So you see the end plate, the pedicle of 5, relatively crisp. So I think that's reasonable. So take a shot here. The first thing that I do is try to mark out that disc level. Take a shot here. So this is the level of the L4-5, this space. I draw a long line here. Now, the next thing I want to do is mark out the midline. Take a shot here. So take a shot. Take a shot here. Take a shot. Oh, the other way, huh? Take a shot there. Okay, so this is the spinous process. And that's the midline. The next thing I want to do is define the level of the pedicle above and below. So take a shot here. Okay, take a shot. Okay, so that's a mid-pedicle of L4. Okay, and take a shot here. This is the L5 of the L5 pedicle. Okay, and then the mid-pedicle, so that's the midline, disc level, midline, mid-pedicle of L4 and L5 on the craniocaudal. Let's take a shot here. Oh, can you, oh, that's fine. Take a shot there. So, take a shot. And that's to the sort of a medial border slash mid-pedicle of to the L4-5 pedicle. Now, where these lines intersect, do you have another pen? Yeah. So, this, depending on what you're doing in terms of a decompression versus a fusion, this is sort of a general starting point. Obviously, I have a slide later on, and we can show.
Can you switch over to the slide?
John, quick question. Yeah. Do you vary that those distances according to the patient habitus? In other words, do you have that distance, are you at the periphery of the pedicles with very large patients, or do you vary that with downward, upward migrated discs, for example?
Yeah, so so that exactly according to the patient's body habitus, where the pathology is, the entry point can be varied. So let's say if you're trying to do a more caudally displaced, then you can move your incision a little bit more caudal. Same thing with the cranial. If I'm doing a very obese patient or a very large patient, you can imagine that the L4-5 pedicle is going to be further apart. Now, the important thing is that this is based on these studies from Korea, that you don't want these two incisions to be larger than 5 centimeters apart. Because if you have a lot of soft tissue in the middle and you're triangulating very deep, then you're going to kind of struggle. So you want to keep this two incision. So right now I'm measuring in this patient about 3.5 centimeters, which is fine. You know, you want to do, so if I'm doing a decompression here, I may want to enter around the more of a medial part of the pedicle in terms of lateral medial. If I'm doing a fusion, I want to enter as sort of the mid-pedicle. If I'm doing a extraforaminal, doing a transforaminal approach, then I'll go outside the pedicle my entry point. So that's it. So for these markers, kind of give you a general idea where to start. So I'm standing on the patient's left side. So I'm right-handed. So my left hand is always going to be the scope. My right hand is going to be the tool. So here's the entry point for the bottom. It's going to be my tools, and then this will be my scope. Now, after I go in and take a shot here. Okay, so the bottom hand is too cranial, so I'm going to adjust it. So I'm going to go down more straight up and down. Okay. And then I'm going to come down a little bit more. Take a shot here. Okay, so I'll do a little bit more straight up and down. Okay, take a shot here. So basically, so that's okay. So now I am converged. My two needle is, my tool is coming down here from the 5, and then my camera is coming from here, and it's converging somewhere in around the facet joint. And that's a safe place to start. When I see this, I flip to the lateral. Let's go to the lateral. Oh. Yeah. Oh, okay, we can't see a lateral, huh? Okay. Well, basically on the lateral picture, you want to see these two needles sort of on top of the facet joint. So
Let's go over to the presentation. I think we have an example of that you were trying to explain.
yeah, so that's sort of the typical. You want those two needles to be close to converged. And that picture is a little bit crisscross, but that's okay. You want that two needles to be converged at this level. So you can go to the next slide. Yeah, so this is what I was talking about. For decompressions, you want, I typically like sort of in the medial border of the pedicle. For fusion, sort of mid-pedicle to the lateral border. And then if I'm doing an extraforaminal approach, sort of outside the pedicle, and then you want the needles to be converging. And you can go to the next slide there. So the concept of triangulation, so you want those two tips of the needle to be meeting at your target, and your target is the disc space. So when you do it too far apart, like the first picture, then it's going to be hard to get down to your target. If you want it too close, then your instrument's going to be running into each other. So you want it just perfect. Okay, and then let's go to the next slide. So this is the typical picture. After this, actually, maybe why don't we do that? I make an incision and put the dilator, put the scope in, and I start to visualize. So let's go to the next slide.
That's the last slide.
Oh, that's the last slide. Okay, so maybe we can show. Should we do the introduction of the dilation? Yeah.
Do you want to save that for the soft tissue part, or is that
Okay.
still considered your
Okay,
targeting?
that sounds good. Thank you.
Awesome. Okay, perfect.
We're running a little bit behind, but the targeting, as you guys have seen, is really one of the trickiest points, because when that doesn't work out, you really get lost, right? Soft tissue handling is another big piece of the learning curve, because you have to make an artificial, space. It's not like a joint or like a pulmonary cavity or anything else that you have a space that is available. You have to create this, and it doesn't come natural, and it takes skills. So the next step.